Hi, this is Dr. Evan Osar with Massage Therapy Insider. Welcome to video 2 of the series on low back pain. In the first video, we looked at the 3 myths of low back pain. 1, that clients are tight because they don't stretch enough. And we said the reality is most clients are tight because they're not stable enough. So these postures that they adopt are really postures of stability. I come down in this posture so I can create more proximal stability, either in my neck, my scapula, and or my trunk, or my hips. I'm trying to create stability. Number 2, we talked about the myth of the weak core, that most clients have weak abdominals or weak low back. And we said if you palpate most clients' abdominals and their low back, they're rock hard. They have too much tone. They're over tonified. So these clients are using these gripping and bracing strategies to create stability. So their strategy for stability of stabilizing their core is faulty. So we also want to create a better stabilization strategy for them once we do our release, which we'll do later in this video. 3, that we talked about the myth of the hyperlordotic low back, and that's the reason for low back pain. In fact, for clients with disc problems, the hyperlordotic low back is actually a benefit to them. Most clients that have disc problems, which is many of our low back pain clients, they actually have flexion in their low back. And let me show you what that looks like. Most of our clients will have this hyperlordosis or hyperlordotic through their thoracolumbar junction. So right here at their lower ribs where the thorax turns into the lumbar spine. They arch and hyperextend through their thoracolumbar junction. This then causes them to do a posterior tilt through their pelvis and or lumbar spine flexion, because the more stiff you are here, you have to move somewhere. So these clients will start to get flexion through their lower lumbar spine. And that's why if you put your hand underneath their low back, you can get it underneath at the thoracolumbar junction right here. But when you slide it underneath their lower back, generally you can't get it back there because their lumbar flex and posterior tilted. So our strategy for myofascial release will be to have clients try to get this rib cage down so that we get this thoracopelvic canister, the thorax on top of the pelvis, in a more connected position. So it lines up pelvis, lumbar spine, rib cage, and upper thorax. Part of our release to do that will be to release some of these myofascial structures through the anterior chest and anterior rib cage to get this rib cage to sit back down, because this is a more ideal position of Ellen's thorax, where the thorax and pelvis are lined up and we have a nice symmetry through the abdominal wall. Here, she'll have to use her external obliques to overstabilize herself. Here, she can use her entire abdominal wall to create stability. So I'm going to show you 3 quick releases to help achieve this position. Again, I'm just going to show you real quickly the direction you want to go and how you want to position the body. Then you can go ahead and do the work yourself. So I'm not going to take you through the entire sequence, but I'll show you how we do this in the integrated movement system. So the first thing we want to do is release the anterior thorax and abdominal fascia and pectoral fascia as well. So I'm going to pin down the abdominal fascia here, because again, I want to get that rib cage to connect down to the pelvis. I'm going to pin here, grab her arm, support her arm, and then bring her back as far as she can comfortably go without stressing out her shoulder. And then I'm going to come back, release, pin, come back. Pin the abdominal fascia, bring your arm back to stretch out this whole entire anterior fascial line. Pin, and then come back. Because like I said, when we finish this anterior release, we want her rib cage to be in a more caudal or inferior position, so when we activate the abdominal wall can now function to close down that rib cage and attach the rib cage to the pelvis. The other release I'll do while she's on her back is to help her release through the anterior upper chest, pectoral fascia, as well as the fascia that comes up from here into her neck. So the same concept. My goal is not to stretch her. I'm not trying to stretch her. I'm trying to elongate her and get that fascial line more elongated in a more optimal position. So I'm going to grab her lightly underneath the occiput and do a slight traction up. Again, take notice when you have clients that have either hypertension or severe anterior head carriage and or neck problems. Don't do it on clients that have vascular compromise and or cervical compromise from a disc herniation and or fusion surgery. Again, screen your clients. I'm going to traction, pin and stretch, or a pin, and then I'm going to slightly elongate her fascia this direction towards me. So I'm trying to create this elongation. As you can see, I'm not just jacking her head over, I'm elongating as I lengthen. So I pin, elongate, now create slight length. So I don't need to go very far before Ellen will start to feel the fascial release. So I'm going to pin, get long, again, so I want to bring the fascia down here and get this fascia long here. So we get this elongation effect in a more optimal position. The last release we're going to do, I'm going to have Ellen go face down. And we want to release the thoracolumbar fascia. So again, most clients, again, are that hyperlordotic thoracolumbar junction right here. So I just want to pin fascia here. Again, there's these oblique lines of fascia that go across her back. I'm going to pin here and then take the thoracolumbar fascia down to her opposite glute all the way over her iliac crest. Elongate that fascial line. And I'll come on the other side to do it on this side. I'm going to pin here towards me and then elongate over the other side this direction. So this fascia, these oblique fascial lines start to open up so I can get her from this position to this more optimal position where the rib cage is now aligned better over the top of the pelvis, and we can get her longer through her entire thorax, because again, now what we want to do is once we get these releases, we want to teach her how to stabilize. This is Dr. Evan Osar with Massage Therapy Insider. Catch us in the next video. We're going to show you how to reestablish stabilization of her low back, which will start to take away a lot of your clients' low back pain.